Thank you, Neil. We're so fortunate to have you lay out such a nice conceptual framework for us for getting started in our workshop. And we'll hear a little bit more after lunch from Jeff Levy to the same end. So I want to turn this over to my colleague, Tait, who will moderate the first panel.
Good morning. I'm Tait. I'm one of the Associate Executive Directors at the American Academy of Pediatrics. And that was a great presentation, Neil, as always. And I'm really honored to moderate this first panel because I think it really speaks to the questions we were just talking about. A lot of times when we're talking in terms of funding, do you do this when you write a grant, you know? You do everything, you're working on the budget, you get to the end, and the things that you look at are, well, how much funding do we need, but also accountability and that evaluation piece and that measurement piece and those kind of things. So I think right now, I think it's great that we're starting out talking about funding, right? Because in order to do what Neil talked about, what we all want to happen and what we're looking at, we have to look at those opportunities with respect to funding. So this panel is funding, opportunities and threats, potential for innovation. So that potential for innovation. And I am really honored to be with my panel seated over here, and I'm going to come join you in just one second here. So the panel today, and I'll just at the highest level do the introduction. So Lindsey Browning is from the National Association of Medicaid Directors, NAMD. Mark Friedlander is from Aetna, Behavioral Health. Olivia Shockey is from HRSA, so Health Resources and Services Administration. And Ellen Marie Whelan is from CMMS, the Centers for Medicare and Medicaid Services. So I'm also going to let you introduce yourselves a little bit when I turn it over to you. The issue that and please read the bios because I think that that's incredibly important. They're included in your information. So here's how we're planning on doing this today. We're starting out with an introduction and with a statement of what you do, where you work, just a brief statement of that. Then we have one overarching question that every panel will be addressing, and then I have about 3 questions that our panelists will address. So that's about 20 minutes for the questions we have, and then 20 minutes for questions from you all. So that's what we'll try to do throughout the day or something similar to that. Let me just remind you as we start, well, let me have the introduction of the panel first, so please.
Good morning, everybody. As Fan said, I'm Lindsey Browning with the National Association of Medicaid Directors. For those who don't know, NAMD represents all 56 Medicaid directors. That's the directors of all 50 states, DC, and the territories. We're an independent association, and we represent the single unified voice of Medicaid and really aim to bring together states for collaboration. Medicaid, real quick as some background, together with CHIP, covers 1 in 3 children nationwide. It's a joint federal and state program, and states have significant flexibility to operate the program with federal approval. Medicaid programs look very different from state to state. For instance, differences in how services are delivered and what populations are covered. This is really important context for understanding what innovations work across states, as this will differ from state to state in the context of the program and populations. The behavioral health needs of children in Medicaid are also very important. In addition to the sheer number of kids we cover, we see a higher prevalence of some behavioral health conditions in the populations we serve, such as ADHD. We're also responsible for covering children with really complex needs, such as children in foster care, former foster care children, and children with disabilities. It's estimated also that less than 10% of kids in Medicaid have behavioral health needs, but account for 38% of spending on kids in Medicaid. So there's a real opportunity to drive value to improve quality for this population of kids. Directors across the country are advancing efforts to improve care for kids with behavioral health needs by creating integrated systems of care and coherence for children and to meet their conditions, both behavioral and physical. More than 75% of directors on a recent NAMD survey indicated that they're working on behavioral health reforms, including reforms that impact kids. And states are looking at opportunities to drive improvement for these kids. NAMD, in our role working with states, is really to bring together directors for the exchange of ideas and knowledge sharing. And it's from that experience that I hope to speak to you all today, not about one particular state, but about the landscape of what's going on in behavioral health reforms for kids in Medicaid. So I'm looking to a robust discussion and happy to be here with this distinguished panel and to talk with you all today.
Thank you, Lindsey. Mark, please.
Hi, I'm Mark Friedlander. I'm the medical director for behavioral health on the commercial side of Aetna, so nothing to do with Medicaid. It is a completely different language. It's a different kind of a customer. And just to provide some context, probably 3/4 of the business that I deal with involves self-insured plan sponsors. So Aetna's not really at risk. Aetna's paid an administrative fee. But it's the large corporation that is my true customer. And what these guys are asking me is, what do we need to do as corporate citizen? What demonstrates value for money? How can we know that the services we're paying for are cost effective, are making a difference? And that's the challenge that I have to answer to day in, day out. What can we do in the behavioral health space that's going to move the needle on outcomes measures, on quality, on accountability? What systems changes need to happen? How can we leverage the all the changes that are occurring as a result of ACA and translate it into the behavioral health space? Many of the ACOs that have formed have behavioral health as kind of an afterthought rather than as something that really drives their costs. But we know that when they look at the real cost drivers, there often is behavioral health comorbidity. So I'm looking at this very much from the angle of outcomes, accountability, and quality metrics.
Thank you. Please, Olivia.
Hi, I'm Olivia Shockey, and I'm here from the Health Resources and Services Administration's Bureau of Primary Health Care. And my role within the Bureau is to develop funding opportunity announcements or grant programs for the Health Center program and the cooperative agreements and collaborative partners that support the Health Center program. For those of you that are not familiar, the Health Center program funds about 1,300 grantees across the nation who provide healthcare services to 1 in 15 citizens. We target the neediest populations, underserved and vulnerable populations throughout the United States and territories. And we are excited that we've had the opportunity as part of ACA to offer behavioral health integration funding within the last year to a large chunk of our grantees. We were able to make that funding in 2 different segments in 2014. But it's also important to note that as a base level, all of our health center program grantees, which operate about 9,000 access points or health center sites across the nation, must provide referral to behavioral health care services, and about 3/4 provide more direct access to mental health and substance abuse services, not just referrals. So we expect to see those numbers increase as a result of the behavioral health integration funding, which required the addition of at least 1 new on-site provider and movement along the spectrum toward integrated care.
Thank you so much. Ellen Marie?
So I'm Ellen Marie Whelan. I'm a senior advisor at the CMS Innovation Center, and I'm also serving in the role of acting Chief Population Health Officer at Medicaid and CHIP. And so as the payer, one of the largest payers in the nation, what we're going to talk about today, I think, is the trend that we're looking at to pay for value-based care. And I think that's where opportunities and threats are clearly as we look to move forward. At the Innovation Center, I will say, just going back to what Neil was saying, that we are fortunate now to have Patrick Conway at the helm at both the Innovation Center and wearing a number of different hats at CMS. and fully understanding the direction that we're going. And he apologizes for not being able to be here today, but understanding, I think, as we're moving forward in this movement towards 3.0. At the Innovation Center, we did start off funding many of these Medicare-driven, adult-focused programs, ACOs, bundles, medical homes. But I think we've certainly started to evolve, and we now have a decent presence in pediatrics there. One of the first was our Strong Start program, looking at paying for enhanced prenatal care to decrease prematurity. In our very large Partnerships for Patients program, where we're looking to decrease hospital-acquired conditions, one of our 26 hospital engagement networks is all children's hospitals, and making big headways in looking at reducing their hospital-acquired conditions. After those programs, we then started to look more specifically at models that were coming to us from folks that were really doing the work. And I think that was when Don Berwick was our chief at CMS, hearing from those with boots on the ground saying, we know what to do, but in many cases, policies that CMS had put in place were standing in the way. And so that's the other thing. Although we're going to be talking about funding today, I think we also need to think about, are there other regulatory issues that we as funders can talk about? And so and many of our awardees are here, and we can talk a little bit more about that. But our Healthcare Innovation Awardees, there's a strong handful of pediatric providers there, ranging from ACOs to chronic diseases as well as dental. In our round 2 of the Healthcare Innovation Awards, we specifically looked at our portfolio, and we did beef up our pediatric component there too. 25% of the round 2 are pediatric providers. And since we were looking specifically at special populations, many of them, if not most of them, are looking at children with chronic medical complexity of some sort, clearly with lots of mental and behavioral health issues. The other areas where we're excited to be now moving into is our state innovation models. Of our 17 testing states, 11 are doing something in pediatrics there. And I think, again, there's a range, but many of them are looking at behavioral health. I think as Lindsey talked about, many of those states want to make sure that they are looking at different behavioral mental health. And one of the interesting things about the state innovation model is that we specifically give the money there to governor's offices and not just the Medicaid, because I think there's an opportunity there to look at blended funding streams. And I think the question earlier about the silos, there's an understanding, especially in pediatrics, that these funding streams can come together maybe through the governor's office. And the last that we're now exploring, we haven't yet announced, is accountable health communities. So we're going from the federal to the state and now looking at communities and what that is and how we move forward. And so I'll leave with saying that I think as this movement towards value-based purchasing, value, of course, is quality over cost. And what it is we're measuring as quality, what it is we're going to be paying for is critical, I think, as we move forward. And we really look to the expertise here to help us figure out what are those metrics, how are we measuring quality, especially if payment's going to be tied there.
Thank you. Can you see why they're here? It's a great panel, and thank you for that introduction. So here's the question that you'll be hearing on and off for the rest of the day. It's kind of the overarching question for the different panels. Given the ACA and healthcare reform in general, and what's happening, you've heard some of it from Neil, you've heard some of it just now. From your vantage point, what are the biggest changes that create the greatest opportunities? So that's in the context of course, behavioral and mental health, but the greatest opportunities for prevention, the greatest opportunities for intervention, and the greatest opportunities for promotion of what we're looking at. I bet you have a lot of questions. I've just added 4, but I won't go there yet. So let me turn it back over to the panel just to comment on that highest level. You've already begun to address that, but if you have other comments on that overarching question, please jump in. Please.
I'll go ahead and start and kick off this. It's a really big, broad question, but I'll do my best to offer some thoughts on this. I would preface my comments with saying that, prior to the ACA, states were looking at ways to drive value and promote delivery and payment reform in Medicaid. And because of the needs of the behavioral health population in Medicaid, this has obviously been a focus. I'll just note that the scope of reform in Medicaid is broad. As I mentioned, our operations survey found that all 50 states are engaged in some kind of reform. And directors, 3/4 of directors are pursuing or implementing 4 or more reforms at once. So it's a broad effort that's going on. And more than 3/4 of directors are looking at the population with behavioral health needs. Now, what's changed in the ACA, I think, is really an acceleration of these efforts. We're seeing new funding opportunities to support these reforms moving forward. Some of the federal models were already mentioned, such as the state innovation model, which is looking at multi-payer, broad-scale reform, including integration of behavioral health services. Also, enhanced funding for health homes have impacted this population, looking at those with chronic conditions, including behavioral health needs. Delivery system incentive pools are also taking place through a number of Section 1115 waivers, which are supporting provider-level transformation. And enhanced funding for IT systems. This is a big thing at the state level to really support the data analytics that are necessary for reform. And the piece of funding that I would mention, of course there are others, but enhanced funding for IT systems and looking towards interoperability and exchange of information. This is really key to driving integration and promoting coordination of care for kids. So through this, states are building a comprehensive effort to promote integrated care and looking at ways to promote this for kids with behavioral health needs. I think this was mentioned earlier, but there's also a recognition of the role that social determinants play in these efforts. I don't think a lot of the questions are figured out here yet, but there's definitely a recognition of the need to focus on this piece. So directors are pursuing different strategies in the context of their delivery system, healthcare marketplace, and populations of children that they serve. But I think it's helpful to think about these strategies for integration taking place at 3 levels. The first is at the agency level. Integration is about building linkages across those systems of care that impact kids. It's not just Medicaid that impacts them, but child welfare, juvenile justice, the education system, and others, as I think was mentioned earlier. The second level of integration that I think it's helpful to think about is at the payment level. States are finding new ways to link the way that services are paid for. Traditionally, they've been separate. One insurance card for your mental health needs, one insurance card for your physical health needs. The third level to think about integration to help frame our conversation today, I think, is at the provider level, building linkages between providers to coordinate care and even integrating providers into the same setting. So in addition to better serving children with behavioral health needs, there's been an emerging focus to look upstream to promote value, looking at early intervention efforts for kids. For some of the populations with behavioral health needs, Medicaid really may end up covering them for the rest of their lives. Thus, there's an opportunity to improve quality, reduce costs, and in some cases even keep them from needing the program forever. But to be frank, there are challenges here at the state level to think about prevention. The first is that there's pressure to look at efforts that save costs now, right? In Medicaid, they work under a budget cycle that's often 1 to 2 years. So you're looking at costs and savings in that budget cycle. The second piece that makes it challenging to focus on early intervention is really the external pressures that can limit the vision to look upstream at value. This comes from legislators, providers, other stakeholders, and current beneficiaries who are really focused on shaping the program for the population it serves right now. So the question that I would pose to all of you today, and where it would be helpful for your expertise, is really to think about what the evidence base says here. If there are opportunities for Medicaid to address prevention, which may be limited, where can these have the most impact and the most value for kids with behavioral health needs? So I raise this question and would welcome any thoughts or feedback on this.
Thank you so much, Lindsey. I think we'll just go down the line here and have additional comments, and then we'll move to the next question. So Mark, please.
Great, thanks. I think the biggest opportunities for us on the commercial side are related to transforming the way that behavioral health services are delivered, particularly at the practitioner level. I think the ACA affords us an opportunity to hold providers accountable. To date, there's been very little done, certainly on the commercial side, to evaluate the quality of services that are provided. In many ways, managed care organizations on the commercial side have been passive in paying claims. In part, this is because we cannot tell the difference between the star providers and the duds. The claim comes in and it looks exactly the same. So if a particular patient sees an outpatient provider for 3 sessions and then stops, Is it because that provider was such a superstar that the patient was cured in 3 sessions, or is that provider so obnoxious that the person would rather be depressed and anxious than go back for a 4th session? And our claim system cannot tell the difference. The ACA has kind of put all practitioners on notice that accountability is the new buzzword going forward. Our efforts are aimed at reinforcing that message, identifying how to measure quality, how to reward and incentivize providers to deliver quality, and how to make sure that the services delivered are the appropriate services in the right quantities. In many cases, what providers want to do is provide more and more of what they're comfortable doing. They like operating in their own comfort zone rather than in meeting the patient where the patient's needs are most prominent. And that too provides a challenge for us in steering folks to the right resources for the right reasons and receiving the right kinds of services for their needs. I think the other opportunity that we have on the commercial side is to push behavioral health practitioners to stop operating in their own isolated silo. Too many of them have that mindset, and managed care organizations over the past 20 years have been responsible in part for creating this division between medical and behavioral health. But we have the opportunity through claims, through financial incentives, to push the behavioral health practitioners closer to the medical providers, particularly in primary care settings. We've taken a look at a number of ways of rewarding behavioral health practitioners, incentivizing them to go into primary care practices, to assess and deliver brief services. We've worked with child psychiatrists to provide telephonic consultations to pediatricians. It's slow going. There is a significant level of resistance, but that's kind of the approach that we're taking at this stage. May seem like baby steps compared to the system transformation that's needed, but that's where we've started.
Thank you, Mark. Olivia.
So for the Health Center program, the Affordable Care Act has given the Health Center program an opportunity for tremendous growth and increased involvement in the community, which is really the core of the program in the first place. Through outreach and enrollment funding that we've been able to provide to Health Center program grantees, we've been able to assist more than 9 million people in enrolling in affordable health insurance coverage, which has been a great opportunity to advance health within the community, not just within patients of the health center, but community health as a whole. And we've seen the chance to add health center program grantees and health center sites throughout the course of the fund that we have so greatly benefited from. So starting in 2009 and currently on the street now, we've been able to put out new access point grants to establish new health center sites throughout the nation. We're expecting to make some additional awards in May. Those new access point sites, as I said previously, are required to, at a minimum, provide screening and referral for behavioral health needs, but more than 3/4 of our health centers across the nation provide direct care for behavioral health services. We have also had the opportunity to make grants to more than 430 of our health centers to supplement what they are already doing for behavioral health care and drive integrated services through bringing more providers on site and increasing use of screening and brief intervention with their patients, and that includes youth. About 30% of all of the health center patients are under the age of 18, with the bulk of those being in the group of 12 and under. So we do see a significant number of youth within our health centers and do focus on their needs. In terms of overall promotion and prevention, we have linked with some of the things that have been mentioned by other panelists in terms of driving towards medical records and increased use of electronic healthcare. So we have funded through ACA funding 43 health center controlled networks to work with our health center program grantees to enhance their use of health information technology to drive care. And we've been able to make quality improvement awards to our health centers for the first time in this year to incentivize health centers that are achieving great results with their patients and using more electronic health records to track and report data to HRSA so that we can have a better sense of performance. And I think another thing that we've been able to do is incentivize patient-centered medical home recognition within our health centers, and have seen over 60% receive that recognition to really transform our health centers into integrated sources of care, not just for meeting primary care needs, but care needs across the spectrum, behavioral health, dental, vision, et cetera. And I believe that later we're going to talk a little bit more about measures, and so I'll save the pieces around that that we've been able to do over the last couple of years. But that just gives you a picture of the tremendous impact that the grant funding has been able to make on the health center program and its technical assistance providers.
Thank you so much. Ellen Marie?
So what's left? So I'll go back to, I think, the changing from the fee-for-service to paying for accountability is, I think, the biggest opportunity. Fee-for-service was not a boon for looking at integrated care. We have so many different team players that provide integrated care. We've got parent partners, we've got schools, we've got all sorts of folks that if we really want to integrate behavioral health, mental health with primary care, we have to look across the whole range and also in different locations. And being tied to a fee-for-service system, looking at quantity and not looking at the integration, certainly I think was standing in the way. So we've got this opportunity now to look at patient outcomes and paying and being accountable. But I think that really calls into question what is accountability? What can we look at when we are looking for the duds versus the superstars? And I think in pediatrics, that becomes even more of a challenge. Many of the approved measures, and I know we're merging on the measurement piece here, but the approved or endorsed measures are for healthy children. And I think as we're looking for this subset of children and families, we don't have a robust set of measures. And I think understanding what is it, do we have the data systems? So the other good thing about we're moving away from fee-for-service is we're moving away potentially from claims data. How are we measuring these interactions to be able to demonstrate what is improved care? And maybe I'll just keep going on measurement and go. We are seeing all sorts of really interesting through the Innovation Center and also at Medicaid and some of the different state work, looking at different ways of measuring success that are beyond what's typically thought of as a healthcare delivery system. School readiness, school attendance, housing stability, fabulous things that we can be looking at. We then have to figure out what that means for being accountable for those. That's a whole different question, but I think the challenge that we need to be looking at when we look to see who's getting paid and for what. So it's a lot more work to make sure that those kinds of measures, as the superstar might be doing, and how is it that we're accounting and attributing then payment going back to those kinds of providers.
Thank you. I think we'll just continue on the measurement piece because I think one of the things that we know just from providers and otherwise, I listed 10 different sets of measures that providers could be asked to use, from a primary care perspective, but it changes. And so when we're looking at that accountability piece and the importance of the measurement piece, how is it that we link both just what you said, Ellen Marie? How do we link the accountability piece with the value piece, with what we're asking, and just some? We're actually having a meeting right now looking at the leaders of a lot of different measures across the country, and what does that mean? So, thank you for beginning the discussion on that. I think that's great. So, Olivia, do you want to comment on measures, or Ellen Marie, anything else you want to comment on measures first, and then we'll.
Well, I guess I don't think you want to leave it up to us to do that. I think that this is one of the places that we really do look to see what the community, what industry, what providers are saying, and help us figure out what are the best ways to
Nice.
move forward. And I think we at the Innovation Center, I think HRSA, I think these organizations, we know that we're playing in a new field here. And I hope that many of you have found that we are very open to hearing from leaders in the field and helping us take steps in the next direction.
Thank you. Olivia?
Yeah, I can add that we were excited in 2014 to add a clinical performance measure for our health centers. And when you said 10 sets, I thought, ooh, we have 16 clinical performance measures and some financial performance. There's lots of measures. And there are many other things that we could be measuring. So I think that's a really important point, that we need to look at what needs to be added. For what we are measuring at this point, we've added a depression screening and follow-up measure, but it looks at 12 and older, and it's an NQF measure. And we'll be collecting data on it for the first time with the data set that was recently reported in January, February of this year. So we're excited to see what that initial group of data looks like. But as we discussed in a pre-panel call, that leaves a gap. So there are some areas that we might be able to improve or add measures as we look at children's behavioral health.
Yeah, thank you so much. I think that's what you have to look at too. We talked about on our call, are there gaps? And if so, do we just keep adding measures, or do we prioritize those measures? And if so, who does that? So I think what you're both saying is critically important. Mark, other comments on measures?
Well, what doesn't get measured doesn't change. In my world, I'm still at the level of trying to get our practitioners to measure anything. We've offered incentives for screening. There's coding available for us to be able to track that. And we're seeing very, very little uptake of, the opportunity to boost income. So we're going to have to get at this from a different vantage point. The other thing that I think we have to be very cautious about is making sure that the measures make sense. Certainly things like screening and brief intervention for alcohol and drug use makes a lot of sense. But we took a look at some of our internal data. And what we found was that a very significant percentage of the claims that were submitted to us for payment for screening and brief intervention were submitted by anesthesiologists. Now, prior to a surgical procedure, the anesthesiologist does an evaluation of their patient to assess their risks, to assess their medical health, and many of them were also adding screening and brief intervention for alcohol use, but there were no referrals. So we were seeing a lot of these anesthesiologists using the screening as a way to add income for their encounter, but we were seeing less than 1% of these folks that were screened landing up with some sort of a referral, as shown by a subsequent claim for treatment for a drug or alcohol problem. So we have to be cautious about making sure that there aren't unintended consequences. And to date, the approach that we've been taking is towards the behavioral health community is please screen. We don't care what you're screening, but please screen, please track symptoms, please report these data so that we can then start refining what makes most sense, certainly in the commercial world, so that we can start arriving at some meaningful measures that aren't too burdensome, but that get at what we're trying to accomplish.
Thank you so much, Mark. I think one of the things that we look at all the time is first the screening, just like you're saying, but then what's the follow-up? And if you think it's hard to track screening, it's much harder to track the follow-up. And unless you're looking at both of those, how do you track outcomes? Ultimately, I mean, you can look at process, but ultimately you want to look at the outcomes of the difference. So thank you for that. Lindsey.
I think there's been a lot of good points made, but I would just key off of one thing, and that's the quantity of measures. I think the challenge for states when thinking about measures for integration are what are those high-value, high-quality measures that can look across populations if possible to see if integration's taken place. I think the challenge here is that integration is defined very differently from state to state, and there's a very diverse understanding of what that truly means. But I think that's an area of opportunity. I think the other area of opportunity is for alignment. We're talking about many different measure programs, measure sets. If there are ways to align those high quality measures of behavioral health integration across programs. It really enhances the feasibility for providers, the feasibility for states, and the feasibility for health plans in reporting and collecting measures.
Thanks, Lindsey. Ellen Marie, you
Yeah,
had another
I just want to
comment.
point out one other, and many of you in the room are probably aware of other federal colleagues that are working on this, and just want to do a shout out to ARC and the measure development that they're doing there, and the good work of, again, of folks probably folks in this room that are doing measure development. And also just a reminder about the Promis Measures that NIH is doing, which is another new area of free web-based measurement, and are they opportunities? So also to let you know that we're not working in silos, or trying not to in the Department of Health and Human Services, that we are working closely with those colleagues in other areas to try to make sure that we're using all those good work that's doing, and then having you all help us figure out which of those might be things that we should be moving forward with.
Ellen Marie, would you mind just commenting on the Promise Measures just a little bit more in case some people
Yeah, so
don't?
I know enough to be dangerous, and I'm sure there's probably folks in the room here that know more, but it's been really impressive. It's they're patient-based, so it's and it's web-based, and they're free measures that I've been most interested in working. I learned about it with the work that Chris Forrest did looking at child well-being.
Mm-hmm.
And they start with many, many questions, and in very rigorous mathematical formulas, they cull it down to a smaller and smaller amount to be able to get some real directionality of the well-being of these kids. And there's all sorts of now different measures, and I'm looking around to see there's probably folks in this room that know a lot more about it than I do, and I'm doing it a disservice. But there's been so much work there. I know that at the Innovation Center, we often don't tell folks which measures to use. We have them tell us which they are using, and many of them are expensive, and this one is free. The fact that it's web-based means the access is available at a much broader level, and it's PROMIS. I don't know what it stands for, but I think it's certainly an area, and if anyone else can be much more eloquent about it than I am, I'd welcome that.
Thank you. We'll hold on to that one, but I just wanted to thank you for bringing that up. So we're just going to spend another 4 or 5 minutes and then open it up to you all. I think the last kind of 2 questions, and you can just address them in any way or form that you want. So we've heard so much already about integration, right? So the mind is not separated from the body, and yet so many times at the state level, at the community level, at the practice level, it is. And I think what we're looking for, which is what Ellen Marie, you were just saying, is that's the expectation at the federal level as it comes down to the states, at the payer level, at whatever level. So if you all would like to comment on any innovation or payment, actually, for that integration. So just comment on the integration of behavioral health, and we just call it health and wellness, right? It's the whole body, right? Health and wellness. So I'll just open that up for a few minutes. Anyone? Lindsey, I'm just looking to you, so we'll just go down the line.
Sure, I'll go ahead and kick it off, and I'll try to be brief. I think here there's a lot of models that could be talked about, and again, the models look very different from state to state. What works in a Medicaid program with managed care is not going to work in a rural or a frontier state with fee-for-service Medicaid, so I'll give that caveat. But I think one of the big models that you're seeing is the use of health homes. These models are addressing those with behavioral health conditions and are looking very different from model to model. But I think the key concept here is, where is the locus of control? Some states have looked at placing that control, the accountability for the health home with the behavioral health provider. This is often for the SPMI populations, those who are going to the behavioral health provider for most of their care. And on the flip side, you see some models where the locus of control is really with the primary care provider. And I'm sure many people in the room can speak to these types of approaches better than I can, but I think it's an interesting model that looks at ways to coordinate services. The second big bucket of models that I kind of wanted to touch on is managed care approaches. I mentioned earlier that payment models have traditionally been separate, right? One insurance card for your physical health services and one insurance card for your behavioral health services. States are looking at various approaches to help integrate the payment model. The first is working under this carve-out approach, right? Linking the accountability for the behavioral health organization and the managed care organization to talk to one another, to coordinate services across health plans. The second bucket of approaches is really carve-in, having one MCO deliver services for the population and coordinate their social and service needs. This model is interesting in that the MCO is really providing for those complex needs and working to fulfill the coordination role. There's also another approach, which is the use of specialty plans. This is another carve-in model where you have more like a behavioral health plan delivering all the services for those with significant persistent mental illness. This is a newer model, but I think it's interesting to see how that'll work. In all of these approaches, states are really looking to build mechanisms into the contract to hold health plans accountable for integrating services and really evaluating the plans to make sure they're prepared to meet beneficiary needs. I think the third thing I would mention is the use of payment models. In some places, we're seeing the use of retroactive payment bundles to hold providers accountable for integrating across care, such as for episodes of care like ADHD. This model really benchmarks a provider's performance on quality and cost and provides gain sharing or risk sharing based on their comparison to the average. So I think the payment models are starting to develop. I think there's opportunities here, and I think we'll see a variety of approaches that meet the flavor of a state's Medicaid program.
Thank you so much. Mark, comments?
Yeah, just a couple of brief comments. What we've started to do is connect specific behavioral health practitioners with large primary care practices. Unfortunately, it depends very much on the personalities involved. We've seen some primary care practices resist intrusion into their space because it may tie up a revenue-generating consulting room. We've also seen behavioral health practitioners use the opportunity to provide services rent-free, but provide long-term therapy rather than quick evaluations, deal with some of the acute issues, and if necessary, take the patient back to their practice where needed. Clearly, an integrated model in a primary care setting reduces stigma, is much more palatable to individuals, and we've seen great positive responses from patients. It's been the practitioners where there's been a greater level of resistance. The other model that we've figured out a way to pay for is in pain clinics, having behavioral health practitioners in pain clinics, because it's very evident that many of the folks in chronic pain clinics are triple or quadruple involved. They have their underlying medical condition producing the pain. They may have a problem with dependence on controlled substances. They may have an underlying behavioral health condition, and there may be other, social issues, psychosocial issues, the vocational impairment, the disability, that make these folks incredibly complicated and very expensive. And that's kind of been where we've put a lot of effort as well.
Thanks so much, Mark. Olivia?
Well, the health center program's goal is to provide comprehensive primary care services to its 23 million or so patients. And that might mean within the health center or through connections with referral organizations in the community. In 2013, health centers provided over 1 million people with behavioral health care within the health centers themselves. So we're really striving for integrated care models within our health centers and strong linkages with community providers when the level of care that's needed by a patient is not able to be met by the health center. We have seen some efforts going in the opposite direction, or sort of the opposite end of the spectrum as well, where SAMHSA is providing grants for behavioral health providers to have primary care providers co-located or closely connected with their community health centers. So we're doing this kind of on both ends of the spectrum, and I'll shamelessly promote the SAMHSA HRSA Center for Integrated Health Solutions as a resource for our health centers and the community to look at how they might work to integrate these opportunities for care.
Thank you so much, Ellen Marie. And then if you have questions, and surely you do, you might start moving to the microphones. Because this will be our last, I'm skipping my last question and turning it over to you all here. So Ellen Marie, please.
So just a word about the different models. We're seeing lots of fabulous models across different awards, and I think one of the things that we're allowed to do as part of the Affordable Care Act, the Innovation Center can scale and spread successful models, and success is when there are improved outcomes and decreased or not increasing costs. And the challenge there, I think, is what Mark alluded to, is that so many of these are then personality driven. Scaling and spreading when we have a good model is not always so easy. One of the ways I often think about what the federal government's role is when the train tracks were being, the train system was being developed in the United States, the federal government said all trains need to be 14, the tracks are 14 inches apart. And then whatever train you want gets put on there. So allowing that flexibility, my Sprint phone talks to your AT&T phone. What is the federal government's role in having those tracks be 14 inches, allowing them the flexibility as Lindsey and the private sector are talking about doing, but what should we be doing? And I think that comes down lots of times to measurement. How do we know there's success in being able to look across multiple models, allowing that flexibility of what needs to happen based on the community? And I guess the last question that we often ask, and I'd ask you to ask through the day and through the course of this, this gathering and in the workshops, is what's standing in the way of success now?
Nice.
You have a vision for what you think is the right way to do care, and it's money, but it's not just someone writing you a check. There's other things that might be standing in the way. And if they in fact are policies, are there ways that we can work to see what are some of the things that might be standing in the way of successfully integrating these models now?
Thank you. And I see there are a few questions. So we'll go quickly, and if it's a long answer, we might say that's a long answer, and we can address it at the break. To my left, please.
Hi, can you hear me?
Yes.
I'm Shika Anand. I'm from the National Institute for Children's Health Quality, and maybe more importantly, with regards to my question, I'm a community health center pediatrician. And so the question is primarily for Olivia, but for the rest of the panel as well. I so much applaud the efforts of BIPIC and what you've been doing around medical home transformation as well as behavioral health integration. My concern is, in most of the implementation I've seen, children almost completely get excluded from the implementation, that the vast majority of the efforts are adult focused, and that whatever you're prescribing centrally is not carving out or ensuring that children be included. And so I'm curious if there are any plans to change that in the future, or maybe there are things that haven't reached the ground yet that are already being asked of us.
I'm going to write a note on this and take it back to the policy developers, because I think your point is really important, and it's something that came up when we were discussing as a panel before we came to this table, that, oh yeah, if we have a measure about depression that's tailored at 12 and over, and we have measures around child health that are 3 and under, what happens to that gap? And are our measures driving a incentive or disincentive around certain interventions? And so I thank you for that, and I will bring it up, and we'll get back to everyone.
Yeah, thank you so much for the question. I think we're always asking that. What about the kids? What about the kids? Next question, please. And thank you for writing that down. So.
Good morning. I want to speak specifically to Mark and your comments about providers. I'm Bernadette Melnick. I'm from Ohio State University. I'm both a pediatric nurse practitioner and a psychiatric mental health nurse practitioner. I have been privileged to do workshops for pediatricians and nurse practitioners over the last decade on mental health, how to better screen for, identify, and treat. The most common response I hear is, Bern, we don't want to screen. If we screen and we find again, it gets back to referral. But the other piece is we need to do a better job in our curricula in preparing both physicians and nurse practitioners how to do this. The other model we have at Ohio State, we are preparing more dually prepared family nurse practitioners, psych NPs, PNPs, psych NPs. And we're putting those folks in our primary care clinics because then you have people who can treat the whole child. And if you get a child in with recurrent headaches, belly pain, we're not doing expensive testing on the physiological side of things. We can move much quicker in ruling that out and proceeding with evidence-based treatment for anxiety and depressive disorders. So it's another solution, but we need more workforce training dollars to prepare more people like that.
Thank you so much. Mark, do you want to respond? I think this could be to any of us because what we're looking at is that interdisciplinary education and collaborative approach to care. So thank you so much for that comment. Mark, or anyone?
Yes, thank you for those comments. I think it is a critical issue for us. I think in the old carve-out world of the separate behavioral health, the managed behavioral health organization, there was very clear separation in the claims system. If it was a behavioral health diagnosis but a medical provider, that belonged to the one plan. If it was a behavioral health condition and a behavioral health provider, only then would it qualify for coverage under the behavioral health benefit. Certainly things have changed, but I think that old mindset still remains in the provider community, that there is a risk that if a behavioral health diagnosis makes it onto a pediatrician's claim, it's going to get rejected by the system, by the payer. That isn't the case anymore. But I think that urban myth still remains and makes things complicated, particularly if there is a carve-out environment. But your point is well taken. I think there is a greater need for an integrated approach. I think the other complexity comes in, and this is more on the medical side of our plan rather than on the behavioral health side, is when you have these folks that have done the additional training. So you have a pediatrician that isn't just a general pediatrician. They've done additional training in behavioral pediatrics or in developmental pediatrics, so they have an additional credential. I think many medical networks are somewhat reluctant to recognize that additional credential and pay extra for that additional credential because there isn't as much of a shortage of general practice pediatricians as there is of, say, child psychiatrists. And these folks have perhaps priced themselves out of the market when it comes to reimbursement because the general pediatrician is expected to be able to screen and provide basic services.
Thank you. And we'll be hearing more from primary care and addressing this through the day and tomorrow. Debbie?
Debbie Walker, Abt Associates. This is a question that might be for the rest of the day, but I was interested that your panel was focusing on what we were doing, but we did not address some of the key things that Neil had in his model, which is the community level. And the reason I'm raising that, especially with measurement, is the ACO really has that opportunity on how you define population health. If you define it as all those in your panel, which a lot of you were, then you're not going to get there. But if you define it as community and the measures in a community, there's lots more issues with measures. Some of the ACOs are doing that in Oregon and others approaching that. And I hope Jeff might address this later. But we have measures. You're going to need ongoing survey kind of methodology. You're going to need all the measures in one place from all the sectors, which MassChip does in Massachusetts. So the question is, are any of you thinking about moving at a level so that there's joint accountability for what you're doing in the community, and what are those community measures?
Thank you. A great question. I think that question will be addressed throughout, but Ellen Marie, you had a comment.
Well, just quickly, part of what we've been funding is opportunity. I don't know whether you heard when we were saying before that some of our awards are looking at school readiness, school attendance. Washington State is looking at things like housing stability. I think you're right. It's a huge opportunity as we're looking forward. And I think the question then lies in the accountability. How do you become accountable for these things that providers feel like this is outside my locus of control? How do I actually, and Kelly Kelleher has been working on that, and a number of other folks of trying to figure that out. So I think you're right, it's the opportunity, but what it is we're measuring and how you then figure out what that accountability is the challenge.
So great question.
We've been excited to see that a lot of providers are thinking of this in states, and I think people are definitely looking to move that along.
Yeah, thank you. And if it's not totally addressed, we'll keep bringing it back around. Steve?
Steve Downs, Indianapolis. So I'm speaking as a primary care pediatrician here. We are, to quote an earlier article, drowning in guidance. The number of recommended steps that general pediatricians are expected to take on related to just what we're talking about in the room today is more than can be done within a visit. And because quality measures tend to be a little like a drunk looking for the keys under the lamppost, you know, you look where the light is, and pediatricians are overwhelmed. When you measure something, it will improve, but something else will go away and get worse. And so my question is, what thinking has gone into deciding how to prioritize what particular quality measures we're going to go after, because something else is going to be neglected if we go after that measure, so it better be an important one.
I think it's a great point, and I think that, as you said, that will increase. But what I hope is going to happen is that team is going to be bigger than just you now as a pediatrician. Hopefully, there'll be a broader team that can be reimbursed, that it won't have to be you doing it. It can be community health workers. It can be a broader use of RNs in primary care as well as advanced practice nurses, the community pharmacist. So hopefully some of that authority or accountability will be lifted from your plate and into a broader team as we're moving away from the reliance on fee-for-service for individual providers and individual services. Hopefully that can be broader.
Other comment? Thank you, and I think that we are looking at those things too. See, we're just having a meeting to look at prioritization today and tomorrow with ARC and NQF and NCQA and CHA and others, just to begin to address what you're talking about, at least in the context of what we're asking our members to do. Next question, and we have, okay, we'll have those people that are standing up, so go right ahead.
Good morning, Andrew Kessler. I represent a variety of interest providers of substance abuse and mental health care in the States. And my question is something that Lindsey brought up, but anyone can feel free to answer. You mentioned IT and record sharing as a key component, but those of us who work on advocacy in this field know about the regulations concerning confidentiality, and those are for adult patients. I can't imagine what the confidentiality rules are for adolescents and children. Can any of you take a moment to address what roadblocks there may be in terms of record sharing that we would need to reform in order to get better sharing of records, especially when it comes to IT, in order to get faster access to care?
This is Lindsey, and it was something I was going to bring up when we're talking about challenges in this area. 42 CFR Part 2, which I think you're referring to, is the strict regulation around the sharing of substance use disorder data. And again, states have brought this up as a major barrier to integration, right? When you're thinking about whole person care, you can't just exclude these records over here and not allow for their sharing. So it's been really tough for states to figure out ways to bring all that information together to inform coordinated care. And that's something at NAMD that we've really been looking at. And as some of you may be aware, SAMHSA is looking to revise those regulations, and that's something that directors are really interested in weighing in on to make sure that those new rules really support integration of care and the sharing of all health IT, health information to support that care.
Thanks, Lindsey. Any other quick questions? Okay. Thank you for that question. Important. Jose?
Jose Shapusnik, University of Miami. I heard the panel struggling with the issue of quality, and what I may have missed, but I did not hear, is evidence-based practice, and which is one of the mechanisms that in science we think we may have to improve quality. And so I wondered whether the panel could address that. And one example, I forget who said it, there was a mention of brief screening for alcohol and drug abuse. Well, the data on brief screening for alcohol is good. There seem to be good outcomes there. But for drug abuse, the data are not showing any results. And so how do we tie evidence-based interventions to this entire process?
Thank you. I'm taking time out of your break here, but let me have you address that. It's a great question.
It's a critical point, and I think the next question is also, what do we count as strong evidence? I think every one of the models that we're doing at the Innovation Center, they have to show that there is an evidence base, but is evidence a randomized control trial? Is evidence anecdote? I think, where is the evidence? And sometimes we like to move forward somewhere where the evidence may or may not be as strong. And so I think it's a critical point. I think we are trying to look to see what's there, and I think the question might mean at what level do we still move forward? We're fortunate to be able to do that at the Innovation Center now, getting at least some seed funding started. As we move to the next level, what will the benchmark be is the question, I think.
Thank you. Last question over here.
Nathaniel Counts, Mental Health America. And my question, which maybe I'll leave everyone with then, is about legal prevention or legal barriers to prevention and community health activities, and the barriers you face as payers in promoting these activities. And sort of at first blush, what I would guess is the first is disincentives around promoting prevention and lifespan activities. Like, for example, for Aetna, if you do a lot of early life prevention, they can jump ship to Kaiser at any time, and you can't internalize any of those externalities, and they become a free rider. Or if you create externalities for, let's say, someone avoids disability, you don't internalize any of those externalities you create. I could see that being a possible legal barrier to prevention. And then also the sort of the expectation that you provide services, which from a prevention level could get things like P.P. and nurse-family partnerships, but not sort of look at the more fundamental issues that Dr. Helfand brought up about the sort of systemic issues that our society faces. And it'd be hard to get that under the sort of aegis of services. And I was wondering what everyone's thoughts were about legal barriers you face to prevention and community health.
Thank you. I think we'll end with that question. I'm sorry, I know there are more, but we're running over. So questions with respect to legal barriers? Answers with respect to legal barriers. Sorry.
This is Lindsey. I can go ahead and offer a few thoughts on that. You know, as I mentioned before, there are constraints around the budget cycle and how that's set up. But I think another consideration is really when you're looking at savings, who does the savings go to, right? Medicaid is accountable for its expenditures and its savings. But if the savings is going to, say, the education system or another agency, it's difficult to account for that. And I think it makes it interesting that, you know, the funding from CMMI going to governor's offices, thinking about ways to look across agencies and across funding streams. So I just offer that thought.
Thanks, Lindsey. Anyone else? Thoughtful question, though. So we'll get. So I hope that you can appreciate why these wonderful panel members are here. I think you've been wonderful, and let's give them a big hand. I'm sure there are other questions, and maybe you can catch them at this brief break, like 10 minutes, please.